This is Where We Live. I'm Lucy Nalpathanchel. Nearly 9 out of 10 Americans say they want to die at home rather than in a nursing home or hospital. Where do you turn for help when making the decision to end of life care for you or your loved one? Today, Where We Live, we explore palliative care and hospice. Does stigma surrounding death keep us from making plans well in advance of a terminal illness or catastrophic health emergency? Coming up, we'll hear the personal stories of Connecticut residents and talk with a local agency that offers palliative and hospice care. Now, you can join the conversation, 860-275-7266. Email wherewelive@wnpr.org. Find us on Facebook and Twitter @wherewelive. But first, Kaiser Health News reported a recent investigation into hospice care in the U.S. To tell us more, on the phone with us now is Melissa Bailey. She's a Boston-based correspondent for Kaiser Health News. Recently co-reported No One Is Coming, Hospice Patients Abandoned at Death's Door. I should say Melissa's also a former manager, editor, and reporter for the New Haven Independent. Melissa, welcome to Where We Live.
It's great to be back, Lucy.
Well, tell us about your story. It begins with a profile of a family, the Martins in Alaska. How did you learn about them, and what was their story?
So this is one of the families that we came across when we looked at 20,000 records from across the country of hospice inspection reports. And my colleague Janelle Alicia talked to Patricia Martin, who's the wife of Bob Martin. He was a beloved family practice doctor in rural Alaska. He went by the name Dr. Bob. And at the end of his life, he got prostate cancer that spread to his brain, and his wife signed him up for hospice. So while many people think of hospice as a place that you go to die, most people actually get hospice care in the place they already live. So that's what Dr. Martin signed up for. And the hospice in rural Alaska was supposed to be on call 24/7 to give him pain relief and emotional, spiritual support. But when he was moaning in pain and his wife called the hospice, he waited 4 days to get pain pills. And by that time, he couldn't swallow anymore. So then it took 6 more days to get liquid painkillers. And his wife, Patricia, was just frustrated to tears about the whole experience. She said it was just a nightmare, and she wishes it would never happen to anyone else.
This is a very troubling story. You mentioned Kaiser Health News investigation looked at 20,000 government inspection records. How common are these cases, Melissa?
So unfortunately, we found similar stories around the country, and not just in rural areas like this one in Alaska, but also in cities. And I mean, it's important to mention that most people are satisfied with hospice. But when we looked at a national survey, we found that 1 in 5 families said that hospice did not always show up when they needed help. And when we looked through these inspection records, what we did is we zeroed in on 3,200 validated citizen complaints against hospices. So these are complaints where the inspectors actually followed up and found something wrong. And we found that the complaints led investigators to uncover problems at 759 hospices in the past 5 years. And over half of those hospices were cited by inspectors for missing visits or failure to deliver timely care.
You said 759 agencies cited. Out of how many hospice agencies in the U.S., Melissa?
So there are over 4,000 hospices, and we in that 5-year period there were 4,400. We found that over half had some sort of citation, either through routine inspections or through these complaints, which is what the part that we focused on.
Now, coming up, we're going to learn a little bit more about what exactly hospice care and palliative care is. But you were mentioning, in looking at these inspection reports, Melissa, you're talking to us here in Connecticut. Any troubling cases in the state?
Yes, so Connecticut had 34 hospices in business during the 5-year period that we looked at, although some have since merged or closed. And in any state, there are problems uncovered through routine inspections. So in Connecticut, there are about 280 deficiencies cited, so that's different rule violations. But we looked at, there were 14 founded complaints, so meaning that investigators verified that there was something wrong had happened. And one of those complaints was in the Hartford area. The hospice was actually providing 24/7 crisis care for a dying patient in the patient's home. So this was a case where the staff was on hand trying to help, but the staff ran out of pain medication, and the patient was, just reading from the report, quote, restless, moaning, twitching with arms and legs moving for 3 hours while hospice staff waited for more medication. And then the next night, the hospice nurse accidentally cut the dosage in half on this pain pump of liquid medication, and the patient was, quote, agitated, combative, cursing, trying to pull out a urinary catheter all night. So Connecticut inspectors cited that hospice for failing to adequately manage the patient's pain.
Now, if someone's listening and is at the point where they're considering hospice for their loved one, if they wanted to find out this kind of information before they make that decision, would they be able to do so easily, Melissa?
So all of these inspection reports are public information. Unfortunately, they're not always very easy they're not handily available on the web, but you can always ask your state health department for copies of inspection reports related to a given hospice. But one problem for families is that these inspections don't happen very frequently. So you might get an inspection report from several years ago, and maybe that hospice is totally cleaned up, or maybe they changed hands. So they're not a very reliable source of current information.
And how often are they inspected by the federal government?
So hospices are inspected usually by state inspectors who then report to the federal government. But unlike nursing homes, they're not inspected every year. The frequency of inspections has fluctuated wildly according to available Medicare funding. So some hospices have historically gone years without being inspected, and that's changing now. And by 2018, hospices will have to be inspected once every 3 years, but that's still not very often.
In the case of the Martins, the wife filed a complaint. What happens when complaints are put forward by families to state health departments, whoever licenses these providers? I mean, what kind of comfort do the Martins get?
So the Martins actually never heard anything back after their complaint until we called them years later, and she said, she thought she had given up hope that anything would have happened from that complaint. And when we looked at the group of, across the country, hospices that had deficiencies cited, so there were over half of the 4,400 hospices had deficiencies, and in that same time period, only 17 hospices were terminated, meaning they were barred from taking federal money. So usually they just have to write up a plan for how they'll do better in the future.
This is Where We Live. On the phone with me, Melissa Bailey, a Boston-based correspondent for Kaiser Health News. She co-reported the story, No One Is Coming, Hospice Patients Abandoned at Death's Door. They looked at more than 20,000 government inspection reports. Over the last 5 years, families have put forth 3,200 complaints about hospice agencies where hospice providers were found to not be there for the family at the time that they needed them the most. Why is this happening, Melissa? Does it have to do with staffing or the kind of oversight? It appears that the hospice industry, palliative care industry, has really grown since it was first founded here in Connecticut in the mid-'70s.
Yeah, the industry has just exploded. I mean, in 2014, 1 of every 2 people who died in the U.S. used hospice, which on the surface is a wonderful thing. I mean, we want people to have care and attention at the end of life. But it seems to me that just the regulatory system has not caught up with the growth of the industry. And also, a lot of these companies, they just don't have the staff to reach patients. So I talked to a former hospice nurse in New Jersey. She was working for a large for-profit chain hospice. And she said when they signed up patients, they would tell them they'd be there 24/7. But in reality, the staff knew that really wasn't true, that they couldn't make it to the home, especially on weekends, because they just didn't have the staff to get to everyone.
And why is that happening, that they don't have the adequate number of people because they're signing these care agreements with families? Why not the appropriate number of staff members?
So this is an industry that's now dominated by for-profits. Two-thirds of patients are seen by for-profit hospice companies, and those companies are trying to meet a bottom line. And so what we're seeing is really a lot of fraud in the system. So the largest for-profit chain, it's called Vitas. It's owned by the parent company that owns Roto-Rooter. And just yesterday, that company agreed to pay $75 million to the federal government to settle a massive fraud case. The hospice was accused of enrolling patients who weren't really dying in order to bring in more Medicare revenue.
You mentioned Centers for Medicare and Medicaid. What other plans do they have to tighten inspections of hospice providers countrywide?
So there is a new website called Hospice Compare. It doesn't increase the rate of inspection. It doesn't even have inspection reports. But right now it's kind of a skeletal website with just a little bit of information. But starting next year, they will actually have family ratings of hospices. So you can go on and try to have some information that would help you compare hospices against each other.
And we should mention in these instances where families, the hospice provider they chose did not show up, they are paid a flat rate from Medicare for each patient. So even if they aren't coming to the home, they're still getting paid.
Yeah, exactly. That's one reason that the industry is really ripe for abuse is that you get paid regardless of if you visit the home. The hospices get paid a daily fee.
Your story that you co-reported for Kaiser Health News came out more than a week ago. What's been the response? And are there policy changes underway, either from the federal level, or have you heard from particular states that are looking into ways to help families if they encounter an incident like this?
So we've heard stories from around the country of just more stories like the ones we reported of substandard care. One woman said she called a hospice 15 times for help and then gave up and called an ambulance for her mother. Another said the hospice was shorthanded and didn't send enough pain medication. She said her mom, quote, died in agony and fear. So while many people have wonderful experiences on hospice, these stories are showing us that there really are there's still people who really aren't getting the care they need. And I talked to government watchdogs in the Federal Office of Inspector General, and they said they've been calling for stricter oversight of hospice for a decade. And they think there should be different levels of punishment short of just termination, which means you stop funding the hospice entirely, and that can be really disruptive to patients who would lose care. But that kind of change would require legislative change on the federal level.
Melissa Bailey is a Boston-based correspondent for Kaiser Health News. Again, she co-reported the story, No One's Coming, Hospice Patients Abandoned at Death's Door. We'll tweet out a link at Where We Live. Melissa, thank you so much for joining us today, and thank you for doing this investigation.
Thank you, Lucy.
This is Where We Live. I'm Lucy Nalpathanchel. Did you know hospice care in the U.S. first began here in Connecticut? Coming up, we're going to hear from providers about end-of-life decisions. What information is important for people to consider? You can join the conversation, too. Tell us about your experience with your family's encounters with hospice in their lives. 860-275-7266. You can email Where We Live at WNPR.org. Find us on Facebook and Twitter at Where We Live. This is Where We Live. I'm Lucy Nalpathanchel. Today we're talking about end-of-life care. We just heard about a Kaiser Health News investigation that reported on cases involving American families who opted for hospice at home but were not given the care they were promised. Now, the Centers for Disease Control says in 2014 there were 4,000 hospice agencies in the U.S. 60% of them are for-profit providers. How do you decide if hospice or palliative care is right for your family member? Where do you turn when making that decision? decision. What was your experience when a loved one needed hospice? You can join the conversation, 860-275-7266. Find us on Facebook and Twitter at Where We Live. Now, joining me in studio now is Lisa Bessie. She's a registered nurse, clinical education, and quality manager at the Center for Hospice Care, Southeast Connecticut. Lisa, welcome to the show.
Thank you.
Also with us, Tracy Wodach, Vice President of Clinical and Regulatory Services at the Connecticut Association for Healthcare at Home. Tracy, welcome to Where We Live.
Thank you so much, Lucy.
I want to start with Lisa. First, tell us a little bit about the organization that you work for, Center for Hospice Care in the southeast part of the state.
Yeah, we're in the southeast part of the state. We've actually been around for over 30 years. We're a local agency. We're not affiliated with any larger health firms, serving our communities in southeastern Connecticut doing hospice and palliative care.
Now, I mentioned earlier that hospice care in the U.S. started in Connecticut. Can you give us a little history?
Sure. It started actually at the Connecticut Hospice back in the 70s and then kind of grew from there. And actually the Medicare hospice benefit became law in 1982, I believe.
We've been talking a lot about hospice, palliative care. Mm-hmm. Tell us the difference between the two. When we say hospice, what do we mean? And palliative care, the same?
Okay. Let me start with palliative care. Palliative care is really for someone who's facing an illness that may end their life, but they still want to receive treatment that is potentially curable. So they may still be working, they're up, they're about, but they really need some help with palliative care. The whole focus really is on goals, is what is the goal that the patient and their family really want? Do they want to continue curative care? Do they want care that's more restorative to maintain function, or are they really ready to move towards comfort-focused care? With hospice care, you can kind of say all of hospice care is palliative, but not all of palliative care is hospice. So hospice care is really for people who have a prognosis of 6 months or less if the disease follows its normal course, and they've decided that they're ready to stop any kind of curative treatment and really focus on comfort and symptom control.
I mentioned Tracy's with us. Tell us about the Connecticut Association for Healthcare at Home. How are you connected to the hospice agencies in the state?
Sure. The Connecticut Association for Healthcare at Home is a nonprofit member organization that supports, we have 26 of the currently 31 hospice providers in the state. I know you mentioned earlier for-profit versus nonprofit nationally. In Connecticut, we're about 75% nonprofit, 25% for-profit. And what we do is our focus is really to inform, educate, and support our members to help them be successful, quality providers following regulatory regulations, both federal and state. So we do an awful lot of education, best practice. We provide tools, trying to give some standardization.
We heard from the reporter from Kaiser Health News who looked at cases around the country, and she had stressed that the majority of experience that families have with hospice providers is good, but there are these cases where there's neglect and families are not promised the care that they receive. What was your reaction when you read the story or heard about this? I'll start with Lisa.
You know, it's really unfortunate that these are the stories that come to light because there's always going to be bad experiences in any business. If you think about the tiny, tiny number of complaints versus the total number of people that were served in hospice, it's really a small, small percentage. But absolutely, things happen. I think sometimes families don't really understand what hospice can provide. And unfortunately, because of Medicare, we aren't allowed to be there 24/7 to take care of people. Families really sometimes have to step up and help to care for their loved one.
Tracy?
Yeah, there were a couple of statistics that came out. So 3,200 complaints over. Actually, the number of patients, beneficiaries who received care in those 5 years was 9.4 million. So it's less than 1/3%, which truly, as Lisa said, things may happen. We don't want them to happen. We don't condone them. But we really do hope that the general public will look at hospice as a more positive outlook than and course of treatment than to look at the complaints. There are so many good stories that we can tell you. What I can say is that what many of our agencies face in Connecticut is an extremely focused scrutiny by our Department of Public Health to ensure that we are following compliant federal and state regulations. And Melissa mentioned that the surveys by 2018 will be every 3 years. Well, that law actually went into effect 2 years ago, 2.5 years ago, I believe it was. And as soon as it did, our state Department of Public Health jumped right on it, and they are completely up to date. Every single one of our 31 agencies have been surveyed for their federal recertification survey. And so they're on time. We're already done with the every 3 years, and now they'll keep us on a 3-year cycle.
You made a point, Tracy, to stress that in Connecticut, 75% of the providers are nonprofit. Mm-hmm. That's a good thing when we're talking about care.
Well, I don't want to say it's a good thing or a bad thing, because several of the for-profit members several of the for-profit providers are members of ours and very actively involved in our policy development, education, excellent providers. So what we can do is really try to touch all of the providers in Connecticut to help all follow proper compliant courses of treatment and philosophy.
So let's get into the process, because when you get to that moment, it's highly stressful. Mm-hmm. Walk us through Lisa Bessie again. She's the Clinical Education Quality Manager at the Center for Hospice Care, Southeast Connecticut, a registered nurse. How does this subject get brought up, and what are some of the challenges for a family to navigate this?
I think one of the biggest challenges is that everybody's reluctant to talk about it. Nobody wants to talk about the big elephant in the room, which is that the person in the bed is facing a terminal illness and they're going to die in a short period of time. So it's really, if the doctor won't bring it up, families should bring it up. Families should be, patients and families should be talking to each other. What do I want? Do I want to continue this treatment? So many people think if the doctor says it, I have to do it. And that's not necessarily true. That people have a choice in terms of what their treatment that they want, how they want the rest of their lives to go. So bringing it up, talking to the doctor, and if you can't talk to your doctor, talk to a nurse, talk to somebody else. People are certainly welcome to call any hospice and just say, I need some information about what it is.
What happens if a family does bring it up to their doctor, but the doctor's not there yet?
I think you have to keep going back to what are the goals, and really, if the patient's goals are comfort and symptom control, then that's what everybody should follow. But that definitely is a hard thing to do sometimes.
Tracy, you were smiling when I brought that up. Is there a tension there between the doctor and the family and trying to figure out what is best for their loved one, the patient?
I think there can be, and there can be for many ways. Sometimes a patient has gone to her own physician for many, many years, and there's a trust there, and they truly have a friendship developed. So it's a difficult time to bring up such a tough discussion. On the other side, many physicians, when they went through medical school, they really had no training in having conversations about death and dying, which is amazing, because one of the sure things in life is that we will all die. And I don't mean to be morbid at all, but it's important to understand what your choices are so that you as an individual can make choices toward how you want to be treated at end of life, and not wait until the doctor says, okay, it's time. Unfortunately, I think what's happened is because we wait so long, and Connecticut actually is ranked last in the country in length of stay on hospice. We have the shortest length of stay in hospice throughout the country. And that just equates to last-minute hospice referrals. And with that, because we have such last-minute hospice referrals, our patients end up thinking that hospice is equated to imminent death, versus what Lisa said, that you actually qualify with up to 6 months of a prognosis for terminal illness. And it's just, we need to bring it up sooner. And we have a great opportunity coming up, if I can mention that. I'm working with stakeholders throughout Connecticut on a group called Care Decisions Connecticut, which is led by the Connecticut Hospital Association. We're in collaboration with them, and we're having a Care Decisions Connecticut Day on November 14th at Quinnipiac University at the Frank Netter Medical School from 11 a.m. until 2 p.m., and it's all about having conversations. our keynote speaker, one of our keynote speakers, is NPR's own Colin McEnroe, who will speak about his experiences with his father and as he faced difficult decisions toward the end of life.
And we'll tweet out a link to that event at Where We Live. I wanted to take some calls today. We're talking about hospice care and palliative care. If you have a story that you want to share about how your family navigated this moment in your life, you can join the conversation, 860-275-7266. Ellen's calling from New Haven. Ellen, you're on the show.
Yeah, hi. Thanks for taking my call. I just wanted to share a personal experience with hospice. My mom died 2 weeks ago, and she was diagnosed with a fatal heart condition a week before she died, and she was immediately referred to hospice by the doctors in the hospital, who were very caring and very clear about the choices that we face. And because of that, she left the hospital the same day she arrived in an ambulance. She was on 24/7 hospice care with incredibly nurturing, kind women who were clearly really trained, were filling out reports and met with supervisors on a regular basis in my mom's home. And she died surrounded by people that she loved with as little pain and fear as possible. And we are so grateful to the providers and so grateful to the hospital that hooked us up immediately, Yale New Haven. And I guess my question is, with that said, I heard about really alarming reports about hospice, both in the state and elsewhere. And my question is, what kind of policy changes can be made? What can listeners do to help ensure that the incredible care that we received is the norm, and that I know it saved money for Medicare because my mom wasn't in the hospital for a week, and I know it saved. It was invaluable to us in terms of being able to have a caring and a death that allowed us to have some sense of closure and peace.
Well, thank you, Ellen, for your call, and we're sorry to hear about your mother's passing. I'll let Tracy Wodach answer your question again. She's Vice President of Clinical and Regulatory Services at the Connecticut Association for Healthcare at Home.
Yes, Ellen, thank you so much for bringing your story forward, and our condolences to you and your family in the loss of your mom. We're so thankful that we were able to provide excellent hospice care to you, and it was referred timely. I guess the answer to the question that you posed really is the groundwork is currently being laid at both the federal government and through initiatives that we're undertaking in Connecticut. The federal government, I think Melissa outlined somewhat the regulatory changes that are going in place and the oversight. There's a lot more focus on agencies and survey processes, the complaint investigations to ensure that hospices are providing good care. Also, there's some more standardization to the documentation and reporting at the federal level. So there will be on Hospice Compare, although it's a skeleton now, as Melissa reported, it will be robust and it will include quality indicators that all hospice providers are measured equally across the nation, as well as patient satisfaction survey results. So you will see some better reporting and some better oversight. And I think it was just a matter of time to get all of the policies and protocols in place for that to happen. In Connecticut, we actually have a lot of initiatives going on with our Care Decisions Connecticut group that focuses on having conversations and working with the various providers at the hospitals, physician practices, nursing homes, et cetera, so that they can have conversations early enough and recognize those patients just like your mom and have those tough conversations early so that the person can be guided through the proper care at end of life.
Bob's calling from East Lyme. Bob, you're on the show.
Hello, I'm Bob from East Lyme.
And tell us about your experience with hospice, Bob.
Well, it was mine was sort of an interesting development. About 5 years ago, my mother and father passed away, and a hospice in Florida was involved, and I found them to be extraordinarily good. Then shortly after that, my wife was diagnosed with leukemia, which was a about a 5-month run, and then she passed in 2015. The first thing I got involved with the Center for Hospice Care and their help was working through the 7 stages of grief, and that include group therapy sessions, include individual counseling. I'd like to just focus on the positive with hospice. In my case, my wife's death was followed by my first wife's death, and she had passed away 3 months later. And then a month ago, I lost a daughter. So I'll tell you, without the Center for Hospice Care, I would have been down the toilet.
Now, I'm seeing that you're also a former volunteer for Center for Hospice Care. Tell us about that.
Yes, just before my wife was diagnosed with leukemia, I was a volunteer for, just up until recently. And I had the thought in my head that my experience with hospice and sitting with people and providing end-of-life company and visiting folks and doing veterans paintings and so forth, I thought that would really help me get ready for what was obviously going to happen in my future. And as it turned out, that's not true. I mean, you're going to feel the grief, the shock, the anger, the bargaining, the depression, and also rebuilding your life. Hospice helped me get through that. That's why I want to really focus on the positive stuff that hospice has done.
Well, thank you, Bob, for your call. I'll go to Lisa Bessie, who's with the Center for Hospice Care in Southeast Connecticut. Tell us about the volunteer role and how they're able to help families at this time.
Sure. Our volunteers are just wonderful. They do a variety of things. They can, as Bob said, they can sit with patients while their family members maybe go shopping or just take a little bit of a break. We do have volunteers who will sit vigil at the end of life if there's nobody else to sit, so the patient's not alone. We also have volunteers who do wonderful complementary therapy. We have massage therapists. We have Reiki therapists. We have healing touch. We have a number of pet therapy dogs. So we have little dogs all the way from like a Yorkshire all the way up to an Irish Wolfhound. So depending on what size dog someone wants to come visit, they can choose. And then we also have volunteers who help us out in the office.
I want to take one more call. Joe from South Windsor. Joe, you're on the show.
Hi, thanks for taking my call. I had a terrific experience with hospice while my wife was dying from cancer 4 years ago. But I just want to point out that the people who treated my wife prior to arriving at hospice made the hospice care job so much more difficult for them. And in the case of cancer patients, I'm afraid that might often be the case, because to get a cancer patient to accept chemotherapy, you don't say you might live 26 days longer, you might live 6 months longer. You have to build the false hope that we can maybe save you, that maybe somebody's going to cure your kind of cancer, or we're going to have some kind of drug that's matched to your genetic makeup. You have to build that false hope if you're going to get someone to poison themselves to the extent that chemo poisons them. And then once you've built all that false hope, hospice, that's in the business of helping them die, has to be up against all of that denial. And the other family members have to try to navigate their way through both of those processes. I mean, I read everything hospice gave me to read to my wife about end of life, at the end of which she asked me to read it again more slowly, and then read it again and tell her what each sentence meant to me, and then read it again and tell her what gave her the best chance of having a near-death experience where she told God, no, I'm not coming. And you're up against that while you're trying to help comfort the patient and provide palliative care and support while they're inevitably dying. And I wondered if you could speak to how difficult that is for hospice care workers.
Well, thank you, Joe, for sharing your story. I'll go to Lisa Bessie. We touched on this a little bit earlier, and about this, trying to figure out this process when you want to hold on to hope, but you know that your loved one is dying.
Yeah, that's so difficult. I think especially in today's medical world where there's been so many advances, there's always you can treat. And it's, I think, always a shock for people when they get to the point where the doctor says, that's it, we can't treat anymore. I think some of the antidote to that is starting to have the conversation earlier, which references back to what Tracy said about, getting physicians and patients and families comfortable with the idea of actually saying what's going on so that it's not a shock when you get to that point. It certainly is difficult for people, patients and families when they come to that point are not always at the same point of acceptance. So that's one of the things that we do is to try to, you can't force anybody to accept what's going to happen, but at least to make it as easy as you possibly can so that, when the time comes that the person dies, everybody's at least as okay with it as they can be.
This is Where We Live. I'm Lucy Nalpathanchel. Today we're talking about end-of-life care and the challenges caregivers, families can face when seeking treatment for their loved ones. In studio with me, Lisa Bessie, a registered nurse, clinical education and quality manager at the Center for Hospice Care, Southeast Connecticut, and Tracy Wodach, vice president of clinical and regulatory services at the Connecticut Association for Healthcare at Home. After the break, we'll hear more stories of Connecticut residents who've navigated end-of-life care decisions for their loved ones, and you can join the conversation too. 860-275-7266. This is Where We Live. I'm Lucy Nalpathanchel. Today we're talking about hospice and palliative care. Now, these are issues that are not easily people don't have trouble talking about this because it's their personal stories. We put out a call on social media to find listeners who want to share their stories. And one of my coworkers at Connecticut Public Broadcasting Network shared her story with the Where We Live team. We thought it was an important one to hear. Joining us now is Sarah DeFilippis, who works in the marketing department at the Connecticut Public Broadcasting Network. Sarah, welcome to the show.
Thank you for having me.
Now, you told us about your mother and how you navigated some end-of-life care decisions for her. Can you walk us through her diagnosis and how you went through that journey?
Sure. So my mother, this is several years ago now. It's about 7 years ago. And my mother had COPD. So she, didn't have a sort of a traditional terminal diagnosis, or at least, in my experience, it wasn't treated that way. Although, the last year of her life was a trip back and forth between various hospitals and various rehab centers. And I think we went to at least 6 or 7 between those two things, sort of going back and forth, because with COPD you get infections and they're very frail. And so it was very clear to us, to our family, that over that period of time, she had a terminal illness and she was in a lot of pain. So, and all those, over time, all of those hospitalizations and those trips in the ambulance to these various places caused a lot of pain. And we were concerned about how is this going to end? How do we reduce her pain and make this less awful for her? So I started asking the question, because you see a lot of doctors in this process, and I didn't have the benefit of having her. She had a doctor. She lived in Stamford, and when she got really sick, we moved her up here. So we didn't have the benefit of that relationship. So everyone who encountered her was new. So everywhere she went, whether it was the hospital or the new rehab center or whatever, I would always ask the question, so when is it time for hospice? Like, I'd like to engage that, as early as possible, because I really want her to not be in pain, because I really didn't see anybody making her better, right? They'd make her stable, but they wouldn't make her better. And there was reticence there, really, on the part of a lot of doctors. I will say that nurses are not reticent about this. Nurses are sort of champions of hospice, and they will say, "Oh yeah, you definitely want to chase that down." But the doctors themselves were, you have to make some big decisions about that, and then you're going to have to stop treating her, and it was difficult to navigate that. I really so my strategy for that was to just keep asking, and ultimately we did get her into hospice. I think that in retrospect, the reason the environment allowed for that, I actually sadly think was an insurance decision. I think they decided that she couldn't be rehabbed anymore. And that opened the door for me, again, to just ask the question, okay, so can we take her home? Can we bring her, and can we put her in hospice and bring her home? And finally the answer was yes. And she actually was in hospice for about 6 weeks. So we had a really long time of relatively pain-free, peaceful time with her.
You made a point to mention her diagnosis with COPD, and it's not considered terminal, but you felt that it was a terminal illness. Did you feel that there was a disconnect there between the medical providers and your family?
I wonder now whether when you're dealing with an oncologist, I think it's part of the process. I think oncologists are probably really well trained in this, and there's a process, right? I mean, I may be wrong about that, but in my case, I think because she wasn't well known to her doctor, and because it was kind of, it's a disease that maybe is a little more murky from this standpoint. I mean, I don't know how anybody looking at her couldn't understand that she was dying. I mean, she was absolutely dying, and for quite a long time. But I think that you can always cure an infection, right? So that there's a decision that has to be made there about, are we going to continue to try and cure these infections which are curable, right? And I think that's where maybe the relationship wasn't there.
Tracy Wodach is with us again. She is with the Connecticut Association for Healthcare at Home. You were nodding your head a lot while Sarah was telling us a little of her story. You mentioned earlier that in medical schools, death and dying isn't really focused on, right? It's about giving hope and sustaining life. Is that changing in 2017? Are doctors approaching hospice and palliative care differently now?
I think we're beginning to see a change in that, yes. One thing that happened in 2013, our state legislature passed a bill to create a palliative care advisory group that's headed by the Department of Public Health. And their focus is really to look at how we're treating people with serious illness and are we offering proper options, et cetera. And they have a report that just came out this year that is trying to move toward building more program development and education at the medical schools and in nursing schools so that we can have focused information about death and dying and having conversations and do more training so they can feel more comfortable. I think a couple of other nods that I was having during Sarah's presentation was really the overall diagnoses and statistics that show what types of patients we care for under hospice. It's only a little over a third that are cancer patients. Mm-hmm. And the rest of them are end-stage serious illnesses like COPD, which is an end-stage respiratory disease, end-stage heart disease, which is the woman that called in. Dementia is one because that is a terminal illness. Mm-hmm. There are a lot of different illnesses, and I think it's really important for us to get the word out to all providers because you never know who will need end-of-life care and when they'll need it. And the importance of having that conversation very early is so much more positive and effective so that you as a family and your mom can really feel that they're making their own personal choice. The other piece that just got passed this year, we have a statewide MOLST process now, Medical Orders for Life-Sustaining Treatment. And this is a national campaign in Connecticut. We took on a little bit different flavor. We call it medical orders, so an APRN, a PA, or a physician can sit down with the family and the patient when they are at an advanced illness level. I would say, frail, serious, advanced stages. Your mom's description would be perfect for the MOLST document. To sit down with the doctor and go over beyond what they may have in their advanced directives. I don't want to go to the hospital anymore, or I'm okay with going to the hospital. But when I go to the hospital, I don't want to go into the intensive care unit. I don't want to be intubated. Whatever the choices are, it gets written down in a document signed by both the patient and the doctor, and that document is carried with that patient so that their wishes can be followed.
And this is legally binding, so it's stronger than what we hear of a living will to be.
Well, it's an order between a doctor and a patient. So the living will is it doesn't have to be legally binding. The living will I can do a living will with my husband, and I don't need a lawyer to sign anything with me. It's just an advance directive. This is what I want for my life. This is what my husband wants for his. But the medical order for life-sustaining treatment, the MOLST document, actually is a physician's order that gets carried with them so that anywhere they go, it would need to be followed. And it can be changed. If you change your mind, it can be changed. It's not static.
You think that would have helped your mother's situation,
That would have
Sarah?
been incredibly helpful because it really boils down to, like, a living will is, I don't want to be kept alive, under extraordinary circumstances. Well, what are those, right? And in my mother's case, I ended up having to have a lot of, sort of probing conversations with various doctors at times when, standing in the hallway in the hospital kind of times, which weren't the best times, where we were having conversations about, all right, so if we say yes or no to compression, for example, to CPR, what will that do to her? And finally someone confessed, well, it'll probably break her ribs. Well, that was an easy decision for me to make, right? Like, I understood, practically speaking, what would happen to her, and it wasn't solving the goal. The goal was to not provide more pain for us. So, we had to sort of chase those decisions down in a difficult way. And it would have been great to have a piece of paper that said, yes, we want to do this. No, we don't want to do that in practical terms.
Sherry is calling from Baltic. Sherry, you're on the show.
My wife had COPD, and we fought this disease for many years. And then last Christmas, I had to take her to the hospital for the final time. And when they finally told us that there was nothing more they could do for her, they called in hospice, and we brought her home for what they told us she would be alive for 4 to 6 months, but she lasted for 11 days. But they didn't give me a suction machine, and this would have been incredibly helpful because I couldn't get the mucus out of her throat, and that was the most heart-wrenching part because I'm a nurse, and I could have done this myself. And that just broke my heart because I was trying to help my wife, and I couldn't. So, sometimes they need to, and I know they didn't have a lot of time, but, they couldn't be everywhere at one time. But if they would have provided me with just that one piece of equipment, I could have made at least her final night, so much more comfortable for her.
Well, I'm sorry to hear about this, Sherry, but we thank you for calling us. I wanted to get Lisa Bessie to weigh in with Center for Hospice Care Southeast Connecticut. We've been focusing a lot on getting our loved ones into this place where they can be comfortable during their end days. But what also are you able to do for families in the grief process?
Hospice considers patients and families to be one unit. So the family is just as important as the patient. So we focus with social workers, with chaplains, with volunteers on helping both the patient and the family deal with all the incredible emotional issues that come up as people are dying. The other thing that hospice can do is we also are mandated to provide 13 months of bereavement support, which can be incredibly helpful for people. For the family members that are left after the patient dies, because it gives them that support that they need, that they're not there by themselves.
Sarah, tell us about your bereavement. Were you able to get support?
I don't think I knew that was available. This is several years ago now, too, so I don't know if it was at the time, but
it would have helped.
Yeah. I mean, every little bit helps, right?
Yeah.
I mean, for me, understanding the whole experience was where I drew solace, right? And that for me was the difficult part. There was so little information, and it would have been really helpful to just have had access to that.
We're almost out of time, but I wanted to go back to Tracy Wodach. For our listeners who want more information about where do they turn, what can you tell them in the last minute and a half?
Well, it's interesting because I personally get many phone calls in our office I don't want to say every day, but at least once a week I get a call from a family member looking for help and where do I go, what do I do? Our website, cthealthcareathome.org, cthealthcareathome.org. We have a Find Services section that helps you just navigate through where you live, what you want. So if you want hospice services or you just say nursing because you're not sure what you want, you can certainly navigate through, and it'll give you the agencies in your area that provide services. You can simply call an agency and ask questions. You can also call our association and ask questions, I'd be happy to work with any family on that.
Thank you, Tracy Wodach, Vice President of Clinical and Regulatory Services at the Connecticut Association for Healthcare at Home. Also, Lisa Bessie with Center for Hospice Care Southeast Connecticut, and CPBN's Sarah DeFilippis. Thank you for coming in, too.
Thank you.
We're almost out of time. I want to thank senior producer Lydia Brown, our technical producer Kyone Wolf. I'm Lucy Nalpathanchel. Thanks for listening.